Well, welcome everyone. Thank you for joining. I see a lot of emails and faces from across the pond, and this is a live event. I'm about to get started, but just so you know, you're muted if you're not one of the guests, and we're so glad you can join us. And thank you for taking time out of your busy days. I know it's almost supper time in the UK and lunchtime here, so we're excited. So without further ado, we're gonna jump right into it, if that's okay. Welcome back to the Waiting Room Revolution. We are excited to be collaborating with the UK's Pilgrims Hospices and have friends from across the pond on the show today. Pilgrims Hospices has been providing palliative and end-of-life care for over 38 years to people of East Kent, which is about an hour or two east of London, and it's one of the largest hospice charities in the UK. And so today we are thrilled to have on the show today Dr. Andrew Thorns, who is the medical director for Pilgrims Hospices since 2015 and has been a palliative care consultant for over 20 years in East Kent, and Justine Robinson, who is the manager of therapies and well-being, and she is an occupational therapist for 23 years, joining Pilgrims Hospices in 2011. So welcome both to the show today.
Thank you. Welcome.
It's kind of exciting for the people who are joining. It's kind of like a live recording, not quite, it's not live, but you know, live in 2021, like Saturday Night Live or something. But so thank you for joining, and it's a little bit of a different dynamic when it's you know, not pre-recorded. So maybe I could start with Andrew first and then Justine, but tell us, and this is partly because we're introducing you. Yeah, go ahead.
Maybe we should introduce ourselves.
Ah, yes. Well, for our show, our guests listen to us, but I am 𝗪𝗀𝗃. I am a healthcare researcher and co-host of Waiting Room Revolution.
And I'm Dr. 𝗪𝗵𝗵. I'm a palliative care physician in the community. Okay, there. Now you.
Thank you. So we tag team, and we're thrilled to be welcoming you. Partly because you know, we're sort of learning from, we're meeting your audiences and the Canadian ones. So Andrew and then Justine, maybe you could tell us a little bit about your role as medical director and maybe what you love about your job.
Oh, thank you, Sam. And thank you so much for the invitation. I feel honored to follow in the footsteps of some very distinguished people on your podcast, which I think are excellent. So medical director, so I work across Pilgrims Hospices, which, as you say, is a charitable organization which provides inpatient specialist palliative care beds and the community work. But I'm also a consultant at the local hospital, or hospitals. We have 3 hospitals in the area. So I provide input into there as well, alongside 4 or 5 other consultant colleagues now. What do I love about my job? Do you know, I suppose as you go on through medicine, you realize that not everyone is going to survive, that unfortunately we all are going to die at some point. And if you can make that last bit of people's lives that little bit better, that little bit easier, then there's a huge satisfaction in that. My sort of need to try and save life all the time, sort of, I began to realize that wasn't just the way to go forward. It's a much better way just to try and enable people to die comfortably, peacefully, at peace with themselves. So when we achieve that, I think that's a huge success, and I'm really pleased when we do that. And I particularly like my job when I can see people in all the different environments they find themselves in. So I think Stanley was saying before we came on the call about being in people's homes, and it's just so lovely to see people where they need to be, where they should be, managing their symptoms, their issues, supporting their families in their homes when we can, but equally having the access to our beds, so that if they need to come in, they can do so, or should they end up in one of the local hospitals, that we can catch up with them there as well, and try and either get them out of hospital if that's what they need to do, or to make sure they're being treated appropriately there. So that breadth of service that we can offer, I love. And of course, you get to work as a team, and working as a multidisciplinary team, I think, is probably the most enjoyable part of this type of work. So you've got excellent colleagues around that we can work alongside, share ideas, different perspectives, and you can sort of see life from different points of view. There's probably many other reasons, but they're the first 2 that come into my mind as to why I enjoy my job.
And Justine, what is it that you do as the manager of therapies and well-being, and maybe what do you love about your job?
So I manage the occupational therapy teams, the physiotherapy teams, and what we call our wellbeing team, which are our wellbeing practitioners who run the most of the groups within our therapy centres, which is where patients come in for the day and attend groups that are suitable for them. What do I love most about my job? I think I'm probably going to echo a lot of what Andrew's already said. It's the MDT working, being able to work alongside so many skilled colleagues who are enthusiastic and dedicated about what we do. The honour of walking alongside someone in that last year of life, being able to see them in their own home, being able to really feel like we make a difference and work really holistically. I think often in England, in the NHS, occupational therapists can you either get separated into mental health or physical as the main areas you work in. In hospice care, you're working really holistically across all of those areas to get the best possible outcome for the patients, which is, something very special, I think.
Oh, I just was worried that you were going to ask me what I love about my job, because I'm so used to complaining about everything. I'm sitting here thinking, okay, what can I say? Were you going to ask me, Sian? I hope not. But anyway, no, I do love my job. I absolutely love it. But what I wanted to ask these folks was, at what point in a person's illness journey do you begin to interface with them?
Very good question, and one of much debate in the UK, because on average, I think it's about 41 days before people die. If you look at the sort of national, they did a bit of national work on this, and we sit probably slightly better than the average, but around that figure, which if you think 41 days before someone dies isn't really a lot of time to try and identify all of the life's troubles and difficulties that are built up over someone's lifetime, or the family to get on board, to get people adjusted to where they are, to make plans for the future. So it's a very short period of time. However, you will also ask me, well, when is the ideal time? And that's always tricky to know as well, isn't it? The old adage is, would you be surprised if this person dies in the next year? Mm-hmm. Which is what the gold standards framework sort of started off with, which I think is a good thing to consider. Would we be surprised if that was the case? Sorry, my computer's doing something.
It's okay. I can compare that in the US and in Canada, the average amount of time that people get palliative care is about 18 days before death. And a paper, a systematic review from the group in Belgium, Dr. Luc Delians, it showed 18 days too, internationally when they pulled all the meta-analysis. So it is very late. I mean, I think 44 days is ahead of the time, but can I ask a question? And for either of you, do you think that this surprise question, this would you be surprised? I know, Joanne Lynn is one of my mentors, started me on this path. So I've indebted to her in so many ways, but I wonder if early palliative care approach, doesn't need to be defined by time. And it's really about the diagnosis and the needs and how do you, manage those two pieces where it's about, would you be surprised, the surprise question, which sort of triggers all these other things, but also when you realize, maybe people have more complex needs earlier on in their diagnosis and this awareness that there will be a progression.
Oh, completely. Yeah, absolutely. It should be based on needs and not time. I mean, there's a time element to it, isn't it? Because people have to recognize they're coming towards the end of their lives, but it shouldn't be based on the time. And I think the Marsden, I'm right in saying, did some work where they screened their palliative outpatients. And they found that some of the patients with the highest needs still had very good performance status. And they weren't the ones who they would traditionally have referred on to palliative care, but actually when they asked them or took time to ask them, their needs were great. And a lot of their needs weren't necessarily physical needs. A lot of them could be more existential, psychological, social needs. So I quite agree, it should be based on need. And something about the person's place on that journey. I don't know what you guys think, but to me, one of the most important things we do is to get people over this sort of hump, this recognition they're dying, and they can still live on the other side. And for some people, that's a really difficult mountain to climb, to get over this idea they might be dying, and how do they adjust to that? For other people, it's very straightforward and simple. But if you can identify those people who struggle early on, perhaps those who are going to have a difficult time at some point in the future, then they're the ones that would be nice to get involved with early, because then we can start to work with them. I don't know what you feel about that, Justine.
Definitely, and certainly from a well-being point of view, Pilgrims has tried to address that by saying that some of our groups, people can be referred into earlier because they don't necessarily have to become a full service user. They can come in and have you know, the education and the information they might need about managing their breathlessness or their fatigue, or just building a bit of resilience around their diagnosis and coming to terms with that. And then they can go off and don't have to be completely under the hospice for however long. You know, they can get what they need and then be discharged back to their primary caregivers in the community. So we're looking at how we can do that and how patients can kind of weave their journey in and out with the hospice, that it doesn't have to be they come to us and then they're with us. So I think, I mean, that might help people perhaps feel comfortable with coming to the hospice at an earlier stage. You know, I'm always aware it's walking through those doors takes a lot of bravery, and it's not just about getting practitioners to refer early, it's about making it a place where patients and people feel comfortable to come to early.
You know, often I wonder about, well, I can appreciate for people how complicated it is to understand, you know, this idea of what is palliative care, who provides palliative care, how do I get palliative care, when do I need palliative care, or I don't want palliative care. Like, people are so confused by the term. I know here in Canada, we're spending a lot of time trying to, I guess, separate the idea of palliative care specialty services and the philosophy of palliative care and the palliative approach to care, where we're trying to infuse a palliative philosophy alongside any kind of disease management treatments, sort of ebbing and flowing from the time of diagnosis of something like COPD or congestive heart failure or Parkinson's or ALS or whatever illness that's non-curable, that philosophy is woven in by all nurses and all doctors from the time of diagnosis, never labeling someone palliative at a point in time. It's just the natural dance we do across these different management styles, and that a palliative care team or specialty group would come in at intervals from the time of diagnosis until death, when needed, to consult or for special programming, et cetera, et cetera. So many people think that a palliative approach or palliative care is reserved for the last year or the last 44 days or the last 18 days or only provided from specialists. What do you guys think of that over there? This idea that it should be a philosophy or an approach to care for any of these illnesses that we know are not curable.
I've heard you speak about that before, Sammy, and you speak very powerfully about it, and I think you're quite right. And I think Dame Cicely Saunders, when she started all this off in the UK, she felt the hospices wouldn't exist after a period of time. There wouldn't be a need for them because you just instilled that way of working, that approach, as you describe it. And therefore you wouldn't need these other people to do the work for you. It would just be integrated in part of general healthcare. And I still really hope that's something that we might do, because I think good palliative care is just good clinical care, really, a lot of the time. There's still that need, as you say, for those slightly more complex situations. Yes. So I don't think we'll completely get rid of this sort of need for the expert side of things. But as you watch the new sort of medical students coming through, the new doctors coming through, perhaps Justine can talk about from a therapy point of view as well, the nurses coming through, you can see there is this culture developing. It's a culture that sort of shows there is an approach to life or approach to care that you can gain from palliative care, and it can be applied at any time during that person's journey. No, I quite agree.
Most of the people that I meet, to be honest with you, I mean, when I first trained and graduated, I thought I was going to be this pain and symptom specialist doing this most incredible, innovative kind of stuff to help people's symptoms feel better. But to be honest with you, 99% of the time, what people are missing is information. And I find a lot of what I do is help them connect the dots of what's happened to them, where they're at now, and where they're going. So much more information sharing than dabbling in people's symptoms. I mean, I do that also, but do you often have people who, by the time you meet them, are really feeling in the dark?
Yeah.
Yes.
Without a doubt. Without a doubt. I think that, and I'd agree with what you say. I think a lot of a lot of the work I do is information. And I think in that very famous study by 𝗤𝗵𝗗, where they looked at lung cancer patients, either randomized to palliative care at diagnosis or usual care, I think a lot of the work they ended up doing was about information and listening and helping people to make decisions. And I certainly think we do an awful lot of that, without a doubt, especially in the hospital. You see people in the hospital beds and they're fearful and they're frightened, and no one's taken that time to listen. I think it was a quote from yourself that says something about hurry up and listen. Yeah. Because they've been talked at so much, but no one's actually stopped to listen to their concerns, their ideas, to be able to work it through. What do you think, Justine?
Yes, I'd agree. We still see people who, because of the language we use, they still don't have an understanding of what's happening to them. Catherine Mannix talks beautifully about using the D words, but I think even before that, sometimes, I've met patients who've kind of gone, well, I'm not sure if I do have cancer, love, because they told me I had a node or a nodule and it's like, okay, we really need to be careful of our language at all stages. So patients have a very clear understanding. And again, as Andrew said, that they've been listened to. Because the minute someone is full of fear, they shut down listening, that you can't take in any more information. And sometimes they just need to get stuff out before they can take anything else in. And I think that's a big part of what we do, is give people space to be able to explore that and come to terms with what's happened to them, where they are, and be able to really hear in perhaps a more clear language what's possibly coming next.
I just came from a home visit this morning, and without sharing too much information, this gentleman has a pancreatic cancer, and he is going to start chemotherapy, and he has no idea about why he's having chemotherapy, what the goal of the chemotherapy is. He has really very little understanding of what stage his pancreatic cancer is at. And I'm smiling and I'm being very kind and trying to be helpful. And in my mind, I'm thinking, that's not informed consent. And people can argue, well, maybe he was told, but he was overwhelmed and he just forgets. But honestly, I've been in the clinics. Often people are discussing treatment options and the pros and cons of treatment options, without really helping people understand really what the goal of the treatment is and in the context of where they're at in their illness journey. So I leave every home scratching my head almost.
I think one of the most important things we can open with is saying, tell me what you understand about your illness.
Yeah.
And why do you think that is, Sammy? Why do you think that situation arises?
Well, I mean, this is an incredible question that I wish I had the answer for, but I think it's a bunch of different things. I think that truly our colleagues are really busy and really well-intended, and they want to get people on the right treatments for them. So that's the first thing. But I do believe that we have not trained people, doctors, ologists, any kind of ologist, cardiologist, respirologist, to be able to feel comfortable having those conversations where we, like we say in our podcast, walk two roads. Like, let's think about this treatment, but at the same time, let's talk about the what ifs, or where things are at. Because, I mean, whoever saw the patient I saw this morning has cared for people with pancreatic cancer thousands of times. This is not the first patient they will have met. So we know from the literature that our colleagues worry that they're going to make people depressed, sad. They think they're going to give up or jump off a bridge if they tell them the honest truth about the big picture. But the truth is we know that when people are invited, not forced, but when they're invited to have more information, that they feel like they can look forward, not looking forward, but I mean, look to the long view, plan, feel more grounded. I don't know. What do you think, Andrew?
Yeah, no, I'd certainly agree with that. Like I say, if you can get people over that adjustment to the fact they are going to die from this, but they can carry on living and we can show them how to carry on living, I think that's achievable. A couple of other thoughts I'd have is we have an advanced communication skills course here at the hospice. And a couple of times oncologists have come on and said, what I'd like to do is in a 10-minute slot is get somebody coming in expecting chemotherapy and leaving comfortable with the thought that they shouldn't have chemotherapy in 10 minutes. So we go through the sort of the techniques, the approaches, the 𝗧𝗵𝗵_and 𝗏𝗵 model, which a lot of medical schools are using now. We sort of look at the patient listening to start with and use picking up the cues and so on. And both times they've achieved this. So in 10 minutes, the patient comes in all geared up expecting chemotherapy and leaves confident and satisfied that they shouldn't have chemotherapy. It's not the right thing for them to do. Wow. So I think there was a skills issue in there as well. I quite agree. And if we could spread those communication skills a bit further, I suspect that would help. But I do also wonder if there's an innate fear of death that we all have somewhere on the line as well. And of course, the patients have that, so they don't want to go near there. But if some of the professionals have that too, so they're not prepared to start going down that side of the roads, that road, one of the two roads you were describing, then it's never going to move on from there, is it? If neither of us are going to start talking about it, that dance is going in the wrong direction. It's not going in the right direction.
Yeah, but I'm sure from your experience, like even if you can help people prepare and live well, even if you don't use the D word, and that's where there is some space between where they're today and when they're sort of very close or imminently dying, and you really can't avoid it anymore. But going back to that education piece, I'm curious what your thoughts are, because even in that comment from clinicians, it's very telling to me, because they want to, in 10 minutes, help the patient move from A to from this decision to recognizing that maybe chemotherapy isn't right. But isn't it funny? Because if we really were patient-centered, it really should be an invitation to ask them. And even if you only had 10 minutes, I don't know what the outcome will be, but as we shepherd people or walk along with them, they might need more time to come up with a decision. But our job is really to listen. It should be them setting the agenda, as opposed to our agenda being, in 10 minutes, I want them to achieve this. And how do I do that in the most efficient way? It's almost maybe part of the issue, right? It really should be, well, what do the patients want? And how do we figure that out? How do we understand what they have? So anyway, that was just my comment to that. But I did wonder, there's a lot of work about communication skill building, and I think it's critical. And part of Waiting Room Revolution was thinking some of these skills could be taught to patients and families to help them lead their own conversations and maybe even role model for their clinician colleagues, that they're open to this and how to do this, and invite them into the conversation if they're willing to have it and they keep getting rebuffed. So I wonder what your thoughts are about that. The idea that if you think back about some of the skills training, could some of those ideas, thoughts be public facing?
It's a very good point, Sen. Absolutely. And just to go back to my oncology colleagues, they weren't trying to be sort of dictatorial about this. These were patients they suspected probably wouldn't want or didn't want, but how do they explore that rather than just it becoming a routine to give it? So they did sort of see, and certainly the skills that we taught them were about getting the patient to talk and seeing where they were and what's going important. But your point about developing patient skills, yeah, because you see it, don't you? We come across the patient who's just been suddenly referred to us. It's all a new diagnosis and they don't know what's going on or how to deal with these situations. And then you get the other patients who've maybe been in the system for some years, and they know how it works. They know how to get hold of the consultant secretary, and they know that they can demand this to happen or ask for that to happen. They become almost like professionals because they know how to work the system and how to ask the right questions. So it has to be there, doesn't it? And I don't know about you, Justine, but I certainly, talking to a number of patients who've got an appointment coming up, I say, well, why don't you ask these questions? Let's think about the questions you want to ask. You know, if you don't get on with them, but if you ask it this way, or maybe I can send an email and just start that discussion so that then when you're there, the consultant is ready and knowing what you want to talk about. So, but I quite agree. I've never run a session for patients or relatives about how to sort of manage their side of the consultation, but I love the idea of it.
Justine, do you see that when you're doing your trainings, and that idea of well-being, that idea of palliative care must always sort of be just underneath the surface of well-being, I would think.
Yes, yeah, absolutely. I mean, from my own communication point of view, I've done the advanced care planning, and I think the most important thing that comes from, not the advanced care planning, sorry, the advanced communication skills. And the most important skill you are taught on that is to listen and ask a question and then sit back. Because actually what comes out of that is a shorter, more focused session, because you're allowing the person to focus you on what's important to them. It's an interesting idea. It's a really bold idea. I like it. The idea of us perhaps training families and patients and how to do that. I think we probably do on an individual level. I think when we're talking to people, you know, as a therapist or in the wellbeing centres, I think we will often have those conversations and say, well, have you thought about this? You know, maybe if you ask, or have you thought of suggesting? Because sometimes it's about the patient knowing that they're at the point of wanting to stop treatment. They don't want the chemo or the radiotherapy or, you know, whatever anymore. And often it's about helping manage those conversations with their families and their medical teams, and saying, well, have you thought about, you know, discussing it like this? Or so, yeah, I think we probably do that on a one-to-one quite often.
This is how we ended up doing the podcast series, because we were doing all these one-to-one type interventions, as you said, Justine and Andrew, arming people with the types of questions that they could go to the healthcare system and perhaps leach out more information than they had before they asked the questions. And, you know, but they don't all get to see a palliative care specialist in their home. And, you know, we know that we only really see the tip of the iceberg of the people who could benefit from our skills, right? So, you know, I know you guys have listened to the podcast, but we got really, really frustrated with how slowly things were going, training healthcare providers as the middleman or the middle people, you know, so that patients and families were ensured to get the information they need. And we decided we're going rogue. We are going to be public facing. We're going to share this one-on-one stuff we're doing. Justine and Andrew, the types of conversations we're all very comfortable with, but we're going to deliver it right to the people, so that they never ever have to worry about someone identifying them as needing palliative care. That naturally, if they do this well, they will automatically get it from the healthcare system just by being a different kind of patient and family. More activated, more empowered, more armed with the right stuff.
I think there's something to recognize there about privilege as well. We in East Kent, we serve very different socioeconomic groups, and I think, you know, I know when I've had to navigate the system on behalf of someone very close to me. One, I have a healthcare background, but also, you know, I'm white and educated and fairly confident about speaking my mind. But we also see lots of families who aren't, and who, you know, have what we call I don't know if you have the same, white coat syndrome. So when they see a doctor, they sit back and become very passive, because, you know, there's this, well, I don't have an education. This is the person who knows everything, and it's those people I'm really interested in how we empower as well. And how we make sure that their voices are heard in the system, because we know with health outcomes, they're the people who perhaps aren't getting the same service.
It's so true what you say. My experience in our city, we have a mixture of socioeconomic statuses here, but I will say that, I assumed that people who had higher education, who had more money, who, et cetera, would maybe fare better when facing a progressive life-limiting illness. But it hasn't always been my experience, actually. There's other ingredients that seem to bubble to the top that almost predict whether or not people are going to fare well or not. Some of them being, and I appreciate totally what you're saying, Justine, but I do find that the darndest people have someone in their life who's that go-getter, the organizer or the manager, and they're just like a dog with a bone. They're just that kind of assertive person. And when I find people like that in the person's environment, I think, oh, okay, this is going to go better than a bunch of people who are just going to let the healthcare system blow them wherever they go. And so, yeah, someone who's assertive makes a huge difference, or it's just someone who naturally has that style, that they, a curiosity, or they ask a lot of questions. They won't stop until they understand something, even if their education level is lower. There's something about different personalities that fare better than others as well. So yeah, I mean, we meet so many different people, don't we? And I don't think it's a one size fits all, that's for sure. I think what you're saying is we have to appreciate that there's such diversity, and empowering people is going to look different depending on, who you're trying to activate.
Yeah, but it's not even, I know some people don't like the word empower, but it is that what you said earlier about, hurry up and listen. Every person should have an understanding, or basic understanding, or whatever understanding they want of what their illness is, where they are in their illness, what might the future look like, what is the intent of the treatment, what are my options. I mean, I would imagine medical professionals are trying to answer those questions, but it is it's the connect the dots. These are very important cornerstones of what is happening. And if people get lost in that, they really don't have a sense of they lose the control and the choices, the ability to make choices that are good for them. And that's irrespective of finances and et cetera. But
you know what, someone put it in the chat. I just wanted to clarify something. A person had to leave, but said, rah, 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 loving all of this. But a comment about love the idea of having conversations about end of life from the start of when patients are diagnosed. And I think just a point of clarification, when we talk about moving these types of conversations upstream, it's not really about talking about death and dying when someone's first diagnosed with an illness that might have a life expectancy of 10 or 15 years like dementia, or 5 years like ALS. It's not sitting people down and saying, look, you have to know this is going to end in death. So I just wanted to clarify that. It's really about us sharing with patients and families that every one of these illnesses is uniquely felt by the person, but is not the first time we've seen this illness. And that people have a right to know that this illness has a pattern to it right from the get-go if they want it, that it has these milestones, these bus stops, these major decision points along the way. And I welcome you to ask us more about that, because the people that ask more questions feel more grounded and more prepared. So it's infusing an early palliative approach is not about talking about death and dying, unless the person wants to, right from diagnosis. It's about helping them know that there is a roadmap, that things will change over time. There's one thing that's guaranteed about these illnesses. They don't stay the same. They're not just chronic. They don't just stay the same and then suddenly lights out. They have a trajectory, a pattern, a storyline to them that's ever changing, which is why I think an OT, because I know, Justine, you're an OT, and I know that Andrew told us he was trained as an OT. I mean, it's an OT's dream come true because it's a constant adaptation to whatever changes the person comes across that require attention, and not just us pretending like it's not going to happen. So it's about inviting them to know the honest, open truth about how this is going to unfold if they want it.
Yeah, just to clarify, I wasn't OT. My daughter's training to be an OT. That was my link with occupational therapy. But yeah, you're quite.
I thought you were an OT.
No, my daughter is training to be an OT.
You've just come down a few notches, Andrew.
I'm sorry. But you're right, and one of your keys is about customizing your order, as you put it. So tailoring your care plan to your preferences. And I think that's the thing, is it? Because some people like to know every single bit of detail right there and then.
Yeah.
Plan the rest of my life for me. And for other people, it's a much more gentle journey, isn't it? Step by step, or maybe not wanting to know at all. So it's customizing, as you put it so beautifully in your keys, that to that person's needs.
And introducing the idea of advanced care planning at the early stage, and it not being necessarily about just a death plan, but actually, being able to prepare for those changes in advance, knowing that the broad strokes of what this, your illness is possibly going to do for you, and having those plans in place. So, okay, so the next step might be, you're not going to be able to do your stairs at home, just as an example, So what are the plans going to be? Let's, would you like to get those in place now so that we're not hitting crisis? And I think, being able to do that and introduce an advanced care plan, as there's a lady over here who has stage 4 cancer, and she talks about advanced care planning as well-being. Because actually, if you have a truly holistic advanced care plan, not just the medical part of it, but everything, then it is part of your own well-being to have that, and it helps you gain control when perhaps you're at a time in your life when you're feeling like you're losing that quite a lot.
Peace of mind.
Yeah. I think, Sammy, if I was to disagree with you slightly, although every experience is individual, there are certain patterns that emerge, aren't there? There are certain things that tend to happen to certain groups of people in certain ways, which perhaps what Justine's saying. So we have that knowledge, and somehow we have to use that knowledge, don't we, just to start to plan ahead. I think that's important. But quite right, it's not just about the medical need, although sometimes that sort of seems to take the prominence in those situations for some reason.
It's very rare when I ask someone if they're interested in more information about their situation, that they say, no, we're not interested. In fact, like I've rarely has someone said no. Sometimes they get a little bit sheepish and worry what I'm going to say. Like, tell them that they're going to burst into flames at the end, or their head is going to, but they have all these ideas that they're worried you're going to confirm for them. But aside from that, I rarely have ever met someone who has said, yeah, no, we don't want to really know. We don't want to know. If they do say it, it's because usually it's because they're scared of something. When you unpack that a little bit, then they realize there's some course correcting we can do to make them feel better. Yeah.
And sometimes I think it's, and I know I've been guilty of this in the past, probably particularly when I started in palliative care, we're going too fast. So, we're maybe taking them 5 steps down the road, and actually this person can only do the first 2 or 1 or even half a step. And it's about working with that person and walking alongside them at the pace that they can do that.
Yeah, I love that. So not just inviting people, but actually assessing or asking them the degree to which they want information and how they want it, right? Yeah, I agree.
And Sammy, do you think that's something to do with you and your communication skills? So do you think that people sort of choose the people they want to ask these questions to? You know, if you've got someone who you get on with, you have a bond, you have a trusting relationship with, you think you feel safe with,
Yeah.
then they're the person you're gonna, yeah, I do want to explore this. Whereas there's somebody else you perhaps don't quite hit it off, or you're not quite confident about them, then you're less likely to go into those more sensitive areas. Do you think that's an element of it?
I think so, for sure. And I think that because I'm in their home, they probably feel even more comfortable, aside from who I am, but just being in their own environment, they can be themselves. So definitely, I think the right person at the right time, at the right place makes a lot of sense for these conversations. I've had medical students and nurses say, you just took an hour to do all of this. How can you expect other people in their busy clinics to take so much time? Time is everyone's, concern. And what I usually say to people is that, the reason why it's taking me an hour is because I'm meeting this person at this stage of their illness. I've never met them before. There's been lots and lots of doctors and nurses involved who have perhaps been busy doing other things or uncomfortable having these conversations. So it's requiring an hour of my time right now. I'd like to think if we do this well in 20 years, let's just say, that people will have bits and pieces of this conversation along the entire journey so that no one person is responsible for the 1 hour discussion at the end. I mean, there'll always be the 1 hour discussions, but you know what I mean? Like, it shouldn't be the first time they're invited into an honest, open discussion about their illness is when they meet me in their home, when they have on average a couple of months to live. That just seems absolutely unfair to me, when they've had amazing doctors and nurses, touch points along the way, yet I'm the one who invites them to know more about it doesn't seem right to me. I mean, I feel proud of what I do. I feel skilled, and I'm grateful that I can do that for people. But the other part of me, which is what was the fuel for the podcast, is it makes me angry. And I'll be honest with you, I'm a happy person. I'm not always angry, but it makes me really disappointed, really angry, not with any one person, but just in general. It just seems so wrong to me.
Yes, quite agree. It takes me back to 𝗪𝗵𝗵 and her idea that we would sort of do ourselves out of business, which maybe we still might. I mean, your work, like on the podcast, hopefully the work we're doing, the common skills stuff, maybe that might just change that culture in due course by the time we retire, Sammy.
I think there'll always be a role for us. And Catherine Mannix set me straight too, because I was trying to convince her that we shouldn't exist. But no, I think there's always going to be a role for us for complex situations, complex discussions, but I will say 99% of what I do could be done by any well-intended and well-skilled doctor or nurse. There are some complex things we do, but for the most part, I think that, it wouldn't be a far stretch to teach, all OTs, PTs, nurses, doctors, social workers to learn a palliative approach. And like I've said before, are you telling me a cardiologist who knows that system so well, what a far stretch it should be that cardiologist should also know how to care for someone, through the final chapters as well? I'm not a cardiologist. I guess I have high expectations for future training of our healthcare providers, to not just screen, diagnose, get people on treatment, and then not learn the skill of also simultaneously shepherding them through an honest, realistic discussion about where this illness is going and how to care for them at the end.
This is a debate we have in the hospital all the time. And it's an interesting point, isn't it? Because if you take that back to, say, an orthopedic surgeon, I couldn't ever mend a fracture operatively. And orthopedic surgeons perhaps don't see that many dying people. So would I expect them to look after a dying person? You know, maybe we could debate that. Your point about heart failure, I mean, heart failure is, generally speaking, a terminal illness when it gets severe. So you might argue that with cardiologists, frailty consultants, or the healthcare of the elderly, then yes, you would expect them to be able to manage dying people. So there's something about where your role sits, doesn't there, as to what you'd expect of somebody. But I do entirely agree with you that there are certain generic skills that should be across all professionals. The ability to communicate clearly with empathy, for example, you know, that should just be generic, shouldn't it? I don't know if I'd go for 99%. I think that was the figure you quoted. I'd say that there's a lot of work, yes, that could have been done by other people. But there's a lot of work that I think there's probably slightly more than the 99%, I think, or less, whichever way you look at it. Because I think there's something about recognizing that people on that journey. As I said, I think to me, the biggest skill we have is to get people over that adjustment. Actually, you are dying, but you can live on the other side. And I think for a lot of clinicians, they don't spend their time immersed in this as a topic, as a subject. Have walked a number of paths with people to sort of see those different ways that things can happen, and see the different ways that people can adjust, and see the importance of that careful communication to help them to do that. So I probably would say maybe 60-40 rather than 99% at the moment, but it might well change in due course going forward. I really hope it does.
When I was training, I remember it was when I was a medical student, even before I went into family medicine or palliative care, I did an elective. I just was avoiding doing another rotation in internal medicine. I would have done anything, honestly. If you told me to mop the floors, I would have done it. So I did this silly thing called palliative care, and it was a 2-week elective. By the end of the week, I was quite comfortable having serious conversations with people. So I do agree that we are trained, and I have, you and I, all of us have such experience now, but it didn't take much. Even the comment you made before about people learning in 10 minutes how to have serious conversations. Yeah, I have high expectations for training other healthcare providers.
Yeah, the consultation was 10 minutes. The training took a bit longer to get to that point, but obviously, yeah, the consultation was 10 minutes. And I agree similarly. I mean, one of the most influential things that is a medical student went to a hospice. Princess Alice and 𝗏𝗏, and Andrew Hoy was the consultant there, and he had patients lined up who were just happy to talk about dying. So just go and talk to them about dying. And of course, as a 23-year-old, maybe medical student, I'd never talked to anyone about dying before. But it was so influential to meet this lady who I can still picture, who was just very happy for me to talk about it all. She felt quite at peace. She knew she was dying. She had a good life. No problem. And we just talked about what it was going to be like and how she got to that point. Very influential. So we can change things, but I still think that level of experience, like Catherine Mannix in her book, and all the different scenarios she describes, I think sometimes we perhaps take a little bit for granted the journey that we've been on, the number of people that we've seen, the number of experiences that we've had in our professional careers, and how can we just apply that to the different individuals that we come across. But not in any way disagreeing that we should continue to work on improving people's skills, and absolutely your keys to empowering patients and their families, absolutely, without a question.
I would be remiss if I didn't talk a little bit about some of the fundraising challenges that exist in Canada, but I would suspect in the UK as well. I mean, I think I read somewhere that the NHS covers like 20% of the Pilgrims Hospices budget. So 80% of your operating budget, which is almost 11 million pounds in a year, is fundraised each year by the residents. So in some level, it's a testament to the impact you have on your community, because they are, so behind you and year after year of fundraising. But it must be a challenge. And how do you think about that as you're programming and placing, sort of planning ahead and trying to get staff and do all your services?
Oh, completely. Yeah. I mean, there's 750,000 people live in East Kent, and they raise the 11 million pounds every year. So we are hugely indebted to them. But you're quite right, Sandy. It demonstrates the importance people place on this type of care, which is great. And it does sort of raise that question, doesn't it? So where does the hospice charity fit? You know, we are a community provider. How do we influence the community around us? We were talking earlier a little bit about, you know, when should people start talking or thinking about these issues? So how much do we start bringing that work into the community? How much is it about us providing to the community or doing to the community? How much is it about us enabling the community to do it to themselves, to take on that responsibility themselves? And there's huge discussions and debates about that, quite rightly, because the hospices originally were a protest movement, weren't they? They originated because good care wasn't there for people, and it was a sort of alternative. This is a protest movement. So what are we now doing as a social movement now? How are we trying to engage with our community? So, and yes, so we're indebted to the people who raised the money. We're starting up a thing called a Think project. So we're just starting to identify people perhaps early-ish on in their journey, and just getting to start to think about it, not about death and dying necessarily, Sam, as you described, but just to start thinking about the future. You know, what is important to them? What do they need to do? What do they need to think about going forward? Are they sort of engaged with their families about what's happening? What do they need to put in place? And it maybe just starts that journey, starts that discussion. So it's maybe perhaps one thing that we can start to then empower the community, and perhaps not just those people who are poorly, but perhaps taking that out to businesses, to corporate organizations, maybe get them thinking about it as well. Because as we know, talking about dying doesn't make it happen. But if you haven't had that conversation, you haven't started engaging in that process and that journey, then of course it ends up being very difficult at certain times as well. But yeah, and I suppose an advantage to us being a charity, because we can then do the things that we think are important. We're not under sort of government control to meet certain targets or do certain things in a certain way. So we quite like a certain amount of flexibility, but a little bit more cash from our health service would be very helpful. Just at the moment. What do you think, Justine?
Yes, I agree. Yeah, I mean, you know, we're absolutely indebted to the people of East Kent. They're just outstanding in you know, their creativity, how they raise money for us each year. I think I remember being told once that it's around 1 in 7 people know someone who's been directly cared for by Pilgrims Hospices in East Kent. Oh. So that's the kind of personal feeling that the people of East Kent have about about our services and what we do. Certainly we think, you know, we're piloting it after Christmas. To start with, it will be staff running the Think sessions, but the hope is that it will become expert volunteers. So eventually it will be the community running these sessions for the community. You know, we'll offer the training, but I think it's what we were saying, it's that idea of advanced care planning, but it being at an earlier stage, it not necessarily being about just your death plan, but actually all the other things that you can think about along the way as part of your advanced care plan. And that's why we've called it Think, because that's all we want to, you know, we just want to drop those seeds in and hopefully something will, you know, will take root and will just help people start having those conversations.
That's amazing. Yeah. How can we support your work? Donate, right?
Yeah. As Bob Geldof would have said, give us your money. But no, I mean, you know, obviously, you know, sharing everything we do, when you see us on social media, you know, supporting us that way is always really helpful too. You know, as I say, we're very lucky in the way that people donate and get involved and volunteer. You know, volunteers are the lifeblood of the hospice, and we wouldn't be able to run without them. And certainly over COVID, when we couldn't have the volunteers in the building because we needed to stop footfall, yeah, we really felt the lack of them, because they're such a joy to have around for us as well.
And collaborate, I'd throw into that as well, Sam, as well, because, you know, you've got some great ideas from what you've developed here. We've got good ideas. The fact we can come together internationally and share those good ideas, which all helps. If the service can get better, that really helps. If we can evaluate the Think project and it's a really good idea and it works and it changes the way people approach things, and we share that with other people, then that's good. So collaborate, I think, is the other one I'd have.
Sam's an expert, world-renowned researcher. So I'm sure he'll want to get involved in evaluating the Think project and
You're
bringing
very
it back
welcome.
here for us.
Yeah. We're almost at the end. Do you have any questions for us? I know we've been sort of back and forth a bit, but did you have any specific questions for us, Andrew or Justine?
Justine, did you want to go first?
I'm just wondering about with your MDTs, because obviously ours are, really multi-professional. How do you work? Do you have OTs and physios and social workers that are part of your immediate team?
Yeah, so I mean, it's probably different all across our country, province to province. I can say on the team that, so most of the palliative care teams in the hospitals draw on the occupational therapists that work in the hospital. They're not specific to the palliative care team. I think every one of our palliative care teams would love to have an OT or 2 or 10 as part of their team, but they tend to be like the OT working on the stroke floor, or the OT working in cardiology, or the OT. And then in home care where I work, we have home visiting OTs. They're generalists, and we draw on their expertise all the time. But I think it's more of a funding issue, not so much acknowledging the role of the OT or the importance of the OT, but it's usually comes down to funding. But I find them invaluable.
But I think the multidisciplinary team, which is like nurses, clinicians, my sense is, doctors, because of how they're funded, are sort of independent and can do their own, one-on-one consults. And then in some, really great community programs, they're able to have, fundraising so that they can have nurses and other, allied professionals as part of that. But I would say that's not as common. Like, we have home care nurses that have, some of whom might have specialized training. And when you're identified as at end of life, you might get those nurses, but they're not necessarily integrated with the family physician or the palliative care specialist physician that is there. And it isn't, yeah, go ahead.
What I can offer about the program that I'm involved, what we try to do is develop a multidisciplinary team around each patient. So it's a little bit different. We don't have our own, well, we do have some, but it's not that the same multidisciplinary palliative care team takes over the care of everyone. What we do is we say, here's the patient. Who's their family doctor? Is there a nurse that works in that family doctor? Is that practice linked with a pharmacy? And what about the home care people? And so we wrap a multidisciplinary team around each person, but many of them may not be palliative care specialists. So we try to bolster them up and allow them to function as an MDT around the patient. But so that's a more common scenario than an actual palliative care fully stocked multidisciplinary team.
That's very interesting. And my question to you, Sammy, then, which sort of leads on to that slightly, is what proportion of the patients on your service die at home, and what proportion should we be aiming to achieve to enable people to die at home?
CN probably has those stats on the tip of his tongue, but I would say, I'm told 80% of people would prefer to die at home if they had their choice, but I believe we're probably around 40% max. And I think that that's optimistic.
That's like provincially and nationally, that is true. But Andrew, I think he's asking about the patients you see. Do you, after they see you, are you in your, with the way that, our community functions?
Yeah, no, I don't think we're any different, to be honest. I really don't. No.
So yeah, nationally, about 60% of patients die in hospital, and cancer patients maybe have a slightly lower percentage. So maybe like, I think it's 51%, and they're more likely to get palliative home care supports, and probably identified as getting palliative care earlier or getting any palliative care. Still, half of Canadians who die get no palliative care before they die, at least, sort of by the billing records.
I would say the biggest issue we have right now is a massive shortage in home care personal support workers and nurses. And so the burden of care is falling very heavily on the families and their informal crews. And, you know, they're at home just holding down the fort. Sometimes these places look like mini ICUs with no trained professionals coming in to see them. So, I mean, you could be the best palliative care doctor in the world with all the information in the world. We can only do so much when we're really that spread thinly. So people do end up going to the hospital, dying in the hospital, going to hospice, which is a home, going wherever. Families are overstretched here in Canada in a huge way.
I quite agree. It often comes down to just that care, isn't it? And it can be a very frightening place when you're trying to look after somebody at home.
Yeah.
People have to feel safe, don't they?
Yes. Yeah.
Justine and Andrew, I really want to thank you both for joining us today and being on our podcast. And it was such a pleasure to connect. And I hope that we can continue to collaborate and contribute to your amazing work.
We can't wait to learn from you guys. You guys are always, it seems like you're always at least 10 steps ahead of us. So do share.
I'm sure you're catching up very quickly, Sammy, if that's the case. It's been an absolute pleasure. Thank you very much.
Thank you. It's been great to be here today.
Thank you both. Take care, everyone. We'll end the meeting.
Bye.
Yes, have a good night. Bye-bye.